It is great to see so many friends and colleagues that every year at the board review session. And it's also humbling for me in the last couple of days, as some of you probably have seen me sitting in the back and taking notes, and because that this will be my 20th year of recertification. So I share your enthusiasm of learning a lot of new things, but at the same time, there is some pain of going through this as well. What I have done is that to take this review to really the highlights of what we need to know for the boards, and the indications for ICD utilization, and specifically focusing on patients with ischemic heart disease and non-ischemic cardiomyopathy. And you have heard from Dr. Ackerman this morning on the channelopathies, including patients with long QT syndrome, Brugada syndrome, and those are the patient populations. You need to know the indications or the risk stratification for those populations. And while that all of those very selected patient populations, when it comes to primary sudden cardiac death prevention, that these are class 2 indications. The next couple of days, you will hear from Dr. Ullman on hypertrophic cardiomyopathy and ARVD and other congenital structural heart diseases. Again, when it comes to primary prevention, know the indications for the risk stratification, but keeping in mind all of those populations that today we only have class 2 indications because there are no randomized trials. Now, with that as an introduction for the ICD and for the purpose of the board, that what I will take you through is on the indications for ICD utilization for primary sudden cardiac death prevention and secondary sudden cardiac death prevention. I will provide you with a very small amount of background information so you know historically how these recommendations came about, and these are fairly straightforward. And I will highlight a couple areas when you see recordings from defibrillators, and you will recognize some of the basics about sensing and some of the potential problems related to ICD management and how to handle some of the day-to-day occurrences. And two really guidelines that will have all of the information related to ICD utilization. The original guideline that from 2006, as shown on the top of the slide, and while that a device-based update from 2008. These will be the two key publications that for you to review before the boards. When it comes to sudden cardiac death prevention, there is secondary sudden cardiac death prevention. We all recognize that these are the patients who have survived sudden cardiac arrest and with documented ventricular tachycardia or ventricular fibrillation, or these patients have syncope and with inducible ventricular tachycardia or documented ventricular tachycardia. The recurrence of ventricular tachyarrhythmias or recurrent sudden cardiac events that will be 20 to 40%. So this is a high-risk population. While that historically really only 3 studies that led to the current recommendations, and the recommendations today were not likely to change in the many years to come, and because this is a very high risk group of patient population, and the recurrence of sudden cardiac events are high. AVID and a study based out of the North America, U.S., CASH, a European study based out of Germany, and SIDS, a Canadian study. And these were the patients who had a sudden cardiac event, survived, or they had syncope, and with documented ventricular tachycardia. And these patients were randomized to ICD versus pharmacological therapy. And the 3 studies that, even though, as you see, the numbers of the participants randomized into these studies are somewhat small, but there was a clear, very clear trend and consistent observation of those patients who were randomized to ICD had better survival than those patients who were randomized to pharmacological therapy. So these 3 studies that have led to the current recommendations for ICD utilization for sudden cardiac death prevention as a secondary prevention. So survivors of cardiac arrest due to ventricular fibrillation or hemodynamically unstable sustained ventricular tachycardia after evaluation to define the cause of the event and to exclude any completely reversible causes. So this is really a very important sentence to digest, that if indeed the sudden cardiac event was caused by a reversible etiology, and the treatment is to focus on the reversible etiology, while that patient that should not be getting an ICD. On the other hand, that if the sudden death event occurred without a reversible etiology, it is a clear class 1 indication. Patients with structural heart disease and spontaneous sustained ventricular tachycardia, whether hemodynamically stable or not stable. So patient has a sustained ventricular tachycardia in the setting of structural heart disease. Number 3, syncope of undetermined origin with clinically relevant hemodynamically significant sustained VT or VF induced at electrophysiologic study. And so that's a syncope of undetermined etiology, and these are also patients with underlying heart disease. That it is important to know the class 1 indications. It is also important to know the class 3 indications, and these are the patients in whom that we shouldn't consider an ICD. And an expectation of survival with an acceptable functional status for less than 1 year. And this is really one of the challenging areas, but at least in the guideline, we should keep in mind that if a person's overall survival is expected to be at less than 1 year, that particularly that with diminished functional status, and this is the patient population that we often discuss with the patient and the family members about the overall expectations of ICD, but according to the guidelines, these are the patients that we should not consider an ICD for secondary prevention. Incessant VT or VF, people always kind of ask the question, why that's a contraindication? Well, VT and VF has to be controlled before an ICD is recommended, even for secondary prevention. Otherwise, the device will be going off and would not be the right thing to recommend to these patients. Significant psychiatric illnesses that may be aggravated by device implantation or that may preclude systematic follow-up. So patients that with significant psychiatric illnesses, that's also a class 3 indication. New York Heart Functional class 4, who are not candidates for cardiac transplantation or implantation of a CRT device that incorporates both pacing and defibrillator capabilities. And then we will see that included later on, and in my presentation and also Dr. Espinosa's presentation, that all of the ICD trials excluded class 4 patients. And class 4 patients, of course, if they qualify for a CRT device, and that would be the appropriate device, but not ICD alone. Syncope of undetermined cause in patient without inducible ventricular tachyarrhythmias and without structural heart disease. So syncope alone is not a reason for ICD consideration. And lastly, a completely reversible disorder in the absence of structural heart disease. So these are the important components of the guidelines for secondary sudden cardiac death prevention, class 1 indications and class 3 indications. And how about primary sudden cardiac death prevention? Patients with known underlying heart disease and with increased risk of sudden death, and risks may vary depend on the severity of myocardial dysfunction and other markers. And what is, I think, what has happened that very, I think, nicely, at least in our clinical practice, is that at the end of the day, that ejection fraction will be really the one parameter that we need to remember, at least for now in our clinical practice and also for the board review purposes. There are many different risk stratification schemes, and while under investigation, some are for research purposes, but today ejection fraction is the parameter that we follow when we assess risk for primary sudden cardiac death prevention. I listed a number of trials that targeting a variety of different populations that for primary prevention, and in those patients with coronary artery disease, cabbage patch, MUST, MADIT1, MADIT2, SCUD-HEFT, Dynamite, and ARIS. Now, I have a star here with the SCUD-HEFT because SCUD-HEFT included both ischemic heart disease patients and non-ischemic heart disease patients. ICD for primary prevention in the setting of dilated cardiomyopathy or non-ischemic heart disease, and AMIOVERT, CAD, SCUD-HEFT, and DEFINITE. So these are the trials that led to today's recommendation. There's only one summary slide that I put over here showing the data that in favor of ICD in selected patient populations for primary sudden cardiac death prevention. And MADIT1, and you see here, these are the selection criteria on the right-hand side. MADIT1 that study cabbage patch, and MADIT2, DEFINITE, Dynamite, and SCUD-HEFT. And AVID, as you heard, CASH and SIDS are for secondary preventions. And for primary preventions, and the bars are in green, what you see is that all of the studies are essentially on the left side of the unit line, while that cabbage patch and Dynamite that are smack in the middle. Now, these are the important studies to understand, and especially the Dynamite study actually results into the current guidelines when we're talking about acute myocardial infarction. The cabbage patch was a study that among those patients who had the 3-vessel disease who were suitable for coronary artery bypass graft. These patients were, all of the patients received bypass graft surgery, and while half of the patients were randomized to ICD, the other half that were treated with medical therapy. This study was negative, although that there were perhaps quite a number of confounders that potentially that explain this negative results. But one of the key messages from this trial is that when patients that have ischemic heart disease with evidence of ischemia and in the setting of a surgical situation, that the aggressive therapy of the underlying disease is the first that approach to those patients. So let's take a look at the results that from these studies that have led to the current recommendations. In patients with ischemic heart disease, that currently that there is no recommendation as far as ICD for primary sudden cardiac death prevention for those patients with ejection fraction of greater than 40%, because all of the trials have excluded that segment of ischemic heart disease population. And in patients with the ejection fraction of 35% to 40%, and these are the patients that we would consider electrophysiologic study, and especially among those patients with documented non-sustained ventricular tachycardia. And if the EP study that induces sustained ventricular tachycardia and the MUST study demonstrated that ICD that provided a better survival as compared to those patients who did not receive the ICD. In patients with ischemic heart disease with ejection fraction less than or equal to 35%, with class 2 to class 3 symptoms, that SCUD-HEFT that demonstrated that these patients that benefited from ICD. And among those patients with class 1 symptoms, ejection fraction of less than 30%, and MAD2 demonstrated ICD provided by the survival. And ICD is not indicated, and I think this will be a very important information to keep in mind for the boards. ICD is not indicated in patients who suffered an acute myocardial infarction less than 40 days. And the two large studies demonstrated very consistent observation in this segment of the population. And for those patients who had, with class 4 symptoms, and CRT should be considered not a standalone ICD. And how about non-ischemic heart disease? And no indication in patients with ejection fraction of greater than 35%. All of the trials in patients with non-ischemic cardiomyopathy excluded patients with ejection fraction greater than 35%. And I saw earlier this morning there was a question about a non-ischemic dilated cardiomyopathy, about EP study. An electrophysiology study is not useful in risk stratification in patients with non-ischemic cardiomyopathy. And ejection fraction of less than 35%, class 2 to class 3 ICD is indicated. That from Scott Heft and definite, and consider CRT again in patients with class 4 symptoms. So class 1 indication, and ejection fraction of less than 35%, history of myocardial infarction of greater than 40 days, more than 40 days, and New York Heart Association functional class, that 2 and 3. And in patients with non-ischemic dilated cardiomyopathy, ejection fraction of less than 35%, New York Heart Association functional class 2 to 3. So both that for ischemic and non-ischemic heart disease in patients with class 2, class 3 functional class with ejection fraction of less than 35%, where they have class 1 indication, that's for ICD implantation for primary sudden cardiac death prevention. And in patients with ejection fraction of less than 30%, greater than 40 days out from myocardial infarction with New York Heart Association functional class, functional class 1. So for class 1 functional class, that ejection fraction needs to be less than 30%. And non-sustained ventricular tachycardia, prior myocardial infarction, and this is again the group of patients that with ejection fraction between 35 to 40%, and electrophysiology study is useful, and if sustained ventricular tachyarrhythmias are inducible, then ICD is recommended. And so that's really, I kind of put all of the key information related to the board on the indication and the population, and for the ICD consideration for primary sudden cardiac death prevention as secondary prevention, and as the first part of the presentation. And now I'd like to take you through that on some of the E-grams from the defibrillators, and some very simple recognition, and also some of the very commonly encountered questions and issues in day-to-day management of these patients, and then the basic troubleshooting if a person shows up with ICD discharges. And just like reading ECGs and intracardiac recordings, and when we approach the printout of the E-grams from defibrillators, a systematic approach that almost always will lead you to the identification of the potential issues and questions. And when we think about a device, and you will hear from Dr. Espinoza as well on the pacemakers, is that there is a sensing component of the device. That device is really that monitoring the heart cardiac rhythm on a beat-to-beat basis. And the sensing that usually is done, at least to the modern devices, and most times that these are in a bipolar configuration, and there is a tip electrode, and then there is a ring electrode. And when the tip to ring bipolar configuration detection or sensing that is programmed, that we see that there is a ventricular depolarization, when the lead is in the ventricle, and these are fairly sharp deflections and reflecting a near-field sensing of the myocardial depolarization, very sharp deflections, very crisp. While that there is also a far-field configuration when it comes to sensing, and meaning that it is the two bipoles are more separated that by distance. As a result, a larger piece of the myocardium depolarization will be detected by the far-field detection, as you see that often that these are wider and less discrete, and so that when you read these electrocardiograms, that when you see these printout, you recognize that there are channels. There is a channel that for near-field sensing and the far-field sensing. Now, typically, when a printout of a defibrillator that is made available, and of course that most times you don't have these labels on the side, but usually that if it's a dual-chamber device, there is an atrial channel recording, and there is ventricular channel recording, and on the ventricular channel recording, that often that there is a near-field recording and a far-field recording. But what's on the bottom, that is these marker channels. Essentially, that these marker channels that print out these numbers, and these numbers are reflecting that the intervals. And if these numbers are reflecting the atrial channel, then essentially it's telling us the PP, or if the patient, in this case, is in an atrial flutter, is telling us the cycle length of the PP or the flutter waves and how fast it's going. And in the ventricle, it's the same thing, and you see these numbers on the bottom. Essentially, that is what the defibrillator, the ventricular lead, is seeing on a beat-to-beat basis, what are the intervals that are recorded or detected by the device. So if you look at this particular tracing, and immediately you would recognize on the atrial channel, these are going at approximately 300 beats per minute, so rapid atrial flutter, while there is variable AV conduction, while that you see these are the intervals of the ventricular beat-to-beat intervals. So that's usually that once you see a printout like this, just like reading ECGs and intracardiac recordings, and approach these printout in a very systematic manner. And while that defibrillator function, and there are usually two that therapeutic functions, and one is anti-tachycardia pacing, and then the other would be defibrillator discharges. And in this recording, one sees that this person that was in tachycardia, the device marker channel is telling us that the cycle length of the intervals were approximately 360 milliseconds. That's translated to about 160 beats per minute. And that particular rate was programmed to the device, and device is detecting that this as ventricular tachycardia. The device was programmed to overdrive this ventricular tachycardia. As you see, usually these are 8 beats as a kind of a conventional duration. And you see this particular episode of ventricular tachycardia was treated with overdrive pacing, and the tachycardia was terminated. And usually in a person that's with monomorphic ventricular tachycardia in a very steady pace, and if the rate is between 150 to 200 or 220 beats per minute, about 60 to 70% of the time, overdrive pacing can be effective in treating the ventricular tachycardia. 10 to 20% of the time may accelerate the tachycardia into faster VT or ventricular fibrillation. And then the other function that in addition to the anti-tachycardia pacing, and you see that again another tracing, that here that the patient, that this again is a far field recording looking of a very rapid ventricular rate, while the middle channel, that is the atrial channel, and the bottom is a near field of ventricular channel, while again you see the marker channels. So this person was in polymorphic ventricular tachycardia or ventricular fibrillation. The device detected the arrhythmia and delivered a shock. Sinus rhythm was restored. So these are the normal defibrillator functions and targeting different types of ventricular arrhythmias. But how about some of the potential issues that are related to the management of defibrillators? Now, when a person shows up to the hospital or emergency room or phones to the device center and reporting an ICD discharge, that the first question comes in mind that did the device that delivered a discharge in the setting of tachycardia or in the absence of tachycardia? And if the device delivered that the discharge in the setting of tachycardia, was it appropriate for ventricular tachyarrhythmias, or was it inappropriate because of different types of supraventricular tachyarrhythmias leading to rapid ventricular rate, and the device sometimes may not be able to differentiate supraventricular tachycardia with rapid ventricular rate versus ventricular tachyarrhythmias. So this would be one that a part of that diagnostic thinking involved, that defibrillator discharge, that was it for tachyarrhythmias, and it was for tachyarrhythmia, was it appropriate or inappropriate? If there was no tachyarrhythmia, and the question then is going to be that the device or the sensing part of the device was sensing something and led to the device to think that this was a tachyarrhythmia and therefore delivered a discharge. And the question then is going to be, what are the signals the device may be detecting? Are these intracardiac signals, that physiologic signals, but was over-sensing and detecting these signals, and P wave or T waves, or these are extra cardiac signals, and these are the times we think about lead fractures, and we think about some myopotentials or electromagnetic interference. Now, in this particular tracing, without going into the details, and this patient received a defibrillator discharge, and when the EGRAM essentially that showed that the patient that had a tachycardia, very suggestive of atrial tachycardia. And again, that we pay attention to the atrial signals, ventricular signals, and just like you were reading the ECGs, if there is AV dissociation, and then that we can differentiate that ventricular arrhythmias and from supraventricular arrhythmias. And similarly, on the intracardiac EGRAMs, that we can look for those similar features. And if a discharge takes place because of atrial tachycardia, supraventricular tachycardia, or atrial fibrillation with rapid ventricular rate, then that implementation of pharmacological therapies such as AV nodal blocking agents, membrane active drugs to prevent recurrence of these of supraventricular arrhythmias, that should be considered. Then, of course, that if these are recurrent, and these are the rhythms that often today that we could consider ablation. Then there are also that the programming features, and we could consider to reduce or eliminate that these inappropriate discharges because of supraventricular arrhythmias, program ICD to many different zones, so therefore we have a better chance of differentiating supraventricular arrhythmias to ventricular arrhythmias. And some of the devices that the single chamber devices, so there is no atrial lead, and often they are deficient to differentiate atrial arrhythmias from ventricular arrhythmias, because if there is no atrial lead in place, and the device really cannot tell what's going on in the atrium. So in that setting, that sometimes we consider an inserting of or adding an atrial lead in patients with single chamber ICD. Let's go to the other side of the diagnostic tree, is that if the patient had a discharge, but there was no tachyarrhythmia. So one must consider some of the potential interferences or malfunction of the device that leading to the discharge. And this is a situation that a patient that had a couple shocks, and when the patient came to the clinic, and the device was interrogated, and while with physical maneuvers, manipulating the generator, asking the patient doing a number of physical maneuvers with arm movements, that one sees that there are these noises, and that here are the QRS complex for each of the cardiac cycle that are recorded over here. But in between, you see these very discrete noises. And while defibrillator actually thought that these were tachyarrhythmias, because essentially the defibrillator that gave us the marker channel showing the cycle length of 290, 230, 310, and in the VF zone. As a result, if this particular sensing into the VF zone lasts long enough, defibrillator that would charge and discharge that because of these noises. So recognizing that these signals, fairly large, discrete, can be reproduced by physical maneuvers and lead fracture, that would be the diagnosis that in this setting. And evaluation and management of lead fracture, check pacing thresholds and impedance, and chest X-ray, and program ICD to monitor only, so this way that the patient that would not be shocked again inappropriately, manipulate the device in the pocket to try to reproduce that this type of noise, and if necessary, and often it is necessary, that to replace the lead in the setting of a lead fracture. How about this tracing? That this tracing was recorded again in a patient who have received discharges. And in this particular tracing was interesting that you see that these are very fine, high frequency, low amplitude signals, and they come and go, and in this particular patient it seems that occur that right after ventricular pacing, and these signals were detected to be in the ventricular fibrillation zone, and the device charged up and delivered discharge to this patient. And these are myopotentials, and these are sometimes that in the ventricular lead that one sees that these myopotentials may be related that to the local signals that from the diaphragm or in the intercostal muscles. And these, again, situations that one that needs to take into consideration. And also that when this type of oversensing occurs, one again could consider reprogramming the device to a less sensitive setting, so that in that situation there will be a reduced chance of the device to sense these low amplitude and rapid signals. But on the other hand, anytime when an ICD is reprogrammed to be in a less sensitive setting to avoid oversensing in this type of setting, one must go through another consideration, is that making sure that by reducing the sensitivity of detection of the device does not compromise the detection of ventricular fibrillation. And that's the time that you would actually want to take the patient to the lab to do a ventricular fibrillation induction to check the defibrillation threshold to make sure the device continues to be able to adequately detect ventricular fibrillation when you change the sensitivity. And finally, that electromagnetic interference. And this usually should be fairly obvious. The patient is welding and near an area with a large electromagnetic field. And one of the things that would tip you off if you were giving a tracing like this is that this type of interference that can be detected usually both on the ventricular and atrial leads. And while fracture and myopotential sensing are usually isolated to one lead as versus electromagnetic interference that are seen on both of these leads. And finally, that if we're not sure why the device is discharging, and in this particular setting, that seems that on surface lead that the patient was in sinus rhythm, but the patient received a discharge, and then that a magnet over the generator that will disable the ICD shocks, and while that in a patient that who is pacemaker dependent, usually that the device would revert to a nominal mode, but pacing that would continue. In some ICDs, that we have to watch if the magnet is held more than 30 seconds, and it may permanently disable the ICD functions. But that particular scenario that has been pretty much eliminated to the more recent device in the more recent devices, and that once the magnet that the purpose of the magnet use is completed, then one must interrogate the device. And so that in summary, that as far as the ICD management and for the board purposes, we should be comfortable to be able to at least read the ICD printout, and if the ICD discharges, interrogate the device and go down to the diagnostic tree that was this discharge appropriate versus inappropriate, and common causes, as I reviewed, the inappropriate discharges, fast rate with normal device function, and meaning that supraventricular arrhythmias were device lead related malfunction, and then also that at least have some simple solutions on a temporary basis and also on the long-term solutions. So I stop here and thank you for your attention.